the standard 3-minute delay has been observed. I'm thrilled to be here to welcome you to the next Treats talk, our series of talks on translational research ethics, applied topics. As you know, these are about 20-30-minute introductions to the basic ethics issues, the related issues in research or regulation around important central topics in translational research. Today, we are very, very pleased and honored to have Dr. Katharine Head with us today, Katie Head, who's an associate professor of communication studies and director of the health communication PhD program here at IUPUI. And I should say her topic on engaging in research within rural communities, I'm sure she'll say more about how important a topic this is. It has always been important. I think it is now gaining the recognition for the importance and the great harm that has been done by researchers failing to access rural communities adequately in the past. And here in Indiana, we have an amazing opportunity to do that even more than we are now. And I look to Dr. Head for guidance on doing that ethically and effectively. Again, we are she's not one of our faculty members in the BSAP program. Often these are given by faculty from the BSAP program, the Bioethics program of the CTSI. But she is a close friend and colleague to BSAP, working on a number of projects, including a few with Jane Hartsock on communication in genetics, a different area that we'll probably invite her back again sometime to do a Treats talk on. So over to you, Dr. Head. Again, thanks for being here.
Thank you so much. I am going to ask everybody to participate just a little bit here at the beginning. If you want to at least turn your cameras on, I would like you to raise your hand or use the little emojis that Zoom provides. How many people grew up in a rural area? Raise your hand all right. Dr. Beckman, I'll pick on you. Will you unmute yourself?
I didn't realize this was a part of it. Okay.
Yeah, that's what you get. Dr. Beckman, what did you like about growing up in a rural area?
It was a small town and everybody knew everybody. That was great to an extent. From a healthcare perspective, you sort of had your doctor, your entire life for many. I don't live there anymore, but I think sort of the small town feel, knowing everybody, grandparents right next door, kind of a thing.
What, if you could use one word to describe your town that you grew up in, one word that encapsulates kind of a really important thing, what would it be?
Comfortable.
Comfortable. Looking back now as a very educated person who studies health herself, what would you think are sort of the major health issues looking back in your community that you guys grew up with?
Specifically, very low vaccination rates, resistance to fluoride in the water.
Wow.
There you go. There are two big ones.
Yeah, definitely. All right, thank you. Thank you so much. I won't pick on you anymore. Anybody else who grew up in a rural area, do you want to tell me something about your town that you loved or looking back that you reflect on now? I saw some other hands. Tasha, did you say you grew up in a rural area?
Yes, I grew up in a small town.
Very small.
The thing that I liked about it the best is, like she said, everybody knew everyone. No one really leaves. So the same families have been there for forever.
Yeah. If you could look back and maybe pinpoint maybe a really hard issue in that town growing up, something that people struggled with, what would it be?
Struggled with is probably education.
Mm-hmm.
The socioeconomic status and the thought that most people never leave means that there's not a high priority on education.
Good. Thank you. Thank you for sharing that. I wanted us to start today thinking about those of us who come with sort of our own knowledge about growing up and living in rural areas and the importance of listening to people who are from those rural areas as we think about what the problems are and what the strengths are in those communities. So I'm going to share my screen. I always say this, I like on Zoom how we narrate what we're doing, so and everybody knows what we're supposed to be seeing. The title of my talk is Engaging in Research Within Rural Communities. I am from a rural community, and my research career has touched on several different rural projects. So it's been a theme that's run throughout a lot of my research, and it's one of my passions. So I'm really grateful to Dr. Schwartz and to the Center for asking me to do this talk, and I hope I can leave you with some guidance and some thoughts about doing this work. Some of you might be brand new to it or thinking about kind of breaking into it. Some of you may already be doing this work, and I welcome your own expertise and thoughts on some of the perspectives that I'm going to share today. So I want to start with the idea that people who live in rural communities are already starting out with a lot of health disparities. So if we look at some of the statistics that are out there, we know that access to MDs and other specialty healthcare is lacking in rural areas. We know people in rural areas have higher rates of being uninsured or underinsured. People who live in rural areas often face poverty and low income and a lot of the things that come along with that. They often tend to be older, and increasingly rural populations are becoming more racially diverse. We also know that people who live in rural areas engage in some health behaviors that put them at increased risk. So we know people in rural areas tend to smoke more. They tend to have higher diabetes and coronary heart disease. We know mental health care is really lacking in rural areas. The suicide rate for young men in rural areas is much higher than it is for the general population. One of the big rural projects I worked on very early in my career was with the Department of Veteran Affairs and sort of the South Central United States. And we went around to the different community-based outpatient clinics, which are always associated with a VA medical center, to interview mental health care providers out in rural areas. Most people don't know, but most young servicemen and women and veterans are from rural areas, and they're returning to rural areas after Afghanistan and Iraq. Often when we went out to interview mental health care providers in these community-based outpatient clinics, there were no psychiatrists. Usually there was not a psychologist. The main mental health care provider we encountered were social workers, which do great work, right? Social workers do amazing work, but they are usually not trained to provide the type of mental health care that some of our veterans need. So there are access issues to healthcare in general, but mental health care in particular. The digital divide is something that has to be mentioned when we talk about rural health and doing research in rural health. The digital divide is not just that people don't have access to internet, it's that they don't have access to good broadband quality internet. My mom lives in a little rural town in Texas, and she lives 3/4 of a mile from the end of the road where the internet stops. And it doesn't matter how many times she calls the internet company, how many times her neighbors call, they can't get the internet extended down to their houses. So this is a very real problem that people in rural areas face. We also know that people in rural areas have transportation challenges. There is very rarely public transportation in rural areas, even though rural residents usually need to depend on it more. So we know that these stats on rural health are pretty grim when it comes to health disparities. Our neighbors are facing a lot of different struggles, but rural areas, as we heard from some of our attendees when we started, are also full of just really rich, wonderful cultures that provide a really wonderful place to go in and do research and try to tackle some of these health disparity issues. So today during this talk, I want to talk about sort of 4 pillars that have guided my own research in rural health that I learned from my mentors, and that helps influence how I approach this kind of research. And I labeled the talk Research Within Rural Communities, because I want us to focus on that with as much as the in. So these 4 pillars that I want to talk about, and will be kind of the main points of my talk, are the use of gatekeepers when we're doing rural research, the focus on trust with our research participants in our communities, the focus on relevance, the relevance of our research topics to our participants, And not surprisingly, as a communication professor, I'm going to focus a little bit on communication. I have worked on a number of research projects in rural areas, but today I want to use a research project that I worked on when I was at the University of Kentucky. And I'm going to use it as a little bit of a case study. I'm going to spend some time introducing it. And then as we go through these 4 pillars, I'll kind of give examples from that project. So the project I'm going to talk about is a big CDC funded prevention research center that was situated in Eastern Kentucky. It was called the Rural Cancer Prevention Center, and it was focused on cervical, breast, and colorectal cancer among residents in this little 8-county region you can see highlighted on your screen. It was called the CRAD, the Kentucky River Area Development District. This 8-county region has some of the worst health statistics that you're going to see across the country, but particularly when it comes to these 3 cancers. My main area of working on this project was focused on cervical cancer screening and HPV vaccination. Women in that area have a 40% higher likelihood of dying from cervical cancer compared to the national average. So we knew there were some serious health disparities around cancer in this area. This project was situated in an area that was very different from where the university was located in the city of Lexington. This was part of the University of Kentucky. And one of the things that we spent a lot of time doing was getting to know our community and getting to know Appalachia and getting to know this 8-county region. There's a really wonderful article, and I know as part of the talk I can share some resources, but this article does a good job of helping us think about how place and the cultural values and history and employment opportunities and social aspects of the community plays a role in health. And one of the best quotes I love from this article is that the mountains shape these people's lives, both literally and figuratively. And we took that approach as we approached this project and we were working to tackle these cancers. Now, it's important to remember that anytime you are working with marginalized populations, you have to consider your own biases of what this community is like, especially if you are not a member of this community. And so around the time that we were doing this project, Diane Sawyer, who likes to say she's from Kentucky and she understands these people. By the way, she's from Louisville, which is about as far from Appalachia as you can get. Did a 2020 special called Hidden America, Children of the Mountains, where she followed people in Appalachia. And some of the footage was from this 8-county region. And it was a very harsh look. Now, there was a lot of it that wasn't false, but there was a lot of it that she didn't portray. And so this sort of media coverage about this marginalized group shapes how we think about them, shapes how we think about the kind of research or the kind of people that we're going to be working with. Another thing that's really important about rural research and any research where you're going into a culture or a group that you are not a part of is learning how people talk about themselves and learning about what's important to the people who live there and their identity that's tied to that place. And so one of the wonderful things you learn about going to Appalachia is you have to know what to call it. So I'm going to share a quick little video real quick. And Peter, Emily, since your cameras are on, let me know if you can hear the sound.
The safest way to say it is Appalachia. And I have to explain this to people because when I go off on book tours, I find myself being appointed as cultural ambassador. And I will get somewhere west of the Mississippi and people will say Appalachia. I will correct them and they will say, well, that's how we say it around here. So I finally had to come up with a story to explain to them why it's not optional. If you're in Ireland, in the north of Ireland, and you start out in Donegal, that city on the west coast, and you're headed for Belfast, it will take you most of a day to get all the way across Ireland. And you'll be driving on the coast road, where if it's a clear day, you look off to your left, you'll see Scotland in the distance. Well, about halfway, between Donegal and Belfast, there's a walled city, which is hundreds of years old. It was built by the Irish, and they named it the Irish word for oak tree, which is Derry. But a few hundred years ago, the British conquered Ireland, and they changed the name of that town to Londonderry. So it is one town with two names. And so if you stop at a little store along the way and ask directions on how to get to the walled city, you can walk in and tell the man behind the counter that you want to go to Derry or you want to go to Londonderry. And either way, he will tell you how to get there. But you need to know that when you choose what you're going to call that city, you have told that man whether or not he can trust you. You have told him your politics, your religion, which side you're on, and how open he can be with you in one word. Because Derry is what the Irish call it, and Londonderry means you sympathize with the British rule. Appalachia and Appalachia work exactly the same way. Appalachia is the pronunciation of condescension, the pronunciation of the imperialists, the pronunciation of people who do not want to be associated with the place. And Appalachia means that you are on the side that you trust.
So as we think about working with different groups, and for those of you who are researchers on the call and do this kind of work, you know this kind of stuff happens all the time. Even single words we use to describe people or to describe their experiences hold weight. Words have meaning. What we label people has meaning. And these are the things we have to think about and know if we're going to go into these communities and engage with them in our research. So I set up Appalachia as a bit of a case study because of my experience there and because I think it's an interesting cultural area. And I'm going to talk about this Rural Cancer Prevention Center project as we go through those 4 pillars, and I'll bring up examples from that to sort of highlight. All right, so the first pillar or perspective on rural research that I want to talk about is gatekeepers. Gatekeepers, sometimes called cultural ambassadors, they're referenced in many different ways in the literature, but the definition is just individuals, groups, or organizations that act as intermediaries between researchers and participants. It's important to understand that when we work with populations, there's a very big difference between access to a population and cooperation. And gatekeepers, as that intermediary, can play an incredibly important role in doing research in a community or doing research with a community. And we always want to try to strive for the with, for the cooperation. Sometimes, though, thinking about what some of the literature calls the simple exchange perspective or approach can be problematic. Just finding someone or an organization to give you access, right, is not always going to be the best approach. And especially if it's a long-term project, a multi-county project where you're thinking about doing long-term intervention work, maybe, we really have to think thoughtfully about who our gatekeepers are and what role they play. We have to consider the different mechanisms that enhance or hinder that relationship and also enhance or hinder the research. For example, an individual gatekeeper or an organization or a group may have their own motives and their own issues around the health issue that you're trying to tackle. When we worked in Appalachian Kentucky, we actually didn't partner very much with churches, which is a very common thing in other research and other community-based approaches. And one of the reasons was because cervical cancer is caused primarily by a sexually transmitted infection. And working with churches in a very conservative area to try to tackle a cancer caused by STIs was not something that we found was going to be helpful for the research, right? And so that was not a direction that we went. Instead, I want to spend a little bit of time talking about a gatekeeper we did work with. And for anybody from a rural area, you're going to recognize this person in my description. We were really lucky to get connected with a man named Wallace Bates. Wallace lived in that 8-county region. He owned property in that region. His family had lived there for years. He was the vice principal of the junior high. He coached the women's basketball team. He had a real estate license. He was an elder in his church. He mentored young men who were coming out of the juvenile detention center. And on the weekends, he and his brother made moonshine in his garage, which he then used as part of the barter system there in their community, which is really common. He would barter it for, lumber or car parts or things like that. Wallace was an excellent gatekeeper. He was an excellent partner in our research because he was so much a part of that community that if he brought us to a meeting or he brought us to a school and he vouched for us, there was a lot of trust that was already there. If Wallace trusts them and he thinks their motives are good, then I'm on board. So our gatekeepers, our cultural ambassadors have to be the people who care about the research and care about the people. Remember gates and this sort of analogy of a gatekeeper. Gates not only keep people out, but that they protect the people that are inside. And so we have to really respect the role of a gatekeeper when we're working in these communities. So how are some ways you can get started thinking about identifying gatekeepers in a rural area? Well, the first is you need to go to that community and you need to start meeting with stakeholders in the community. Maybe it's you set up a meeting with a local pastor or a local doctor or the mayor or a business owner or the vice principal who's also the coach and the real estate agent and but start with meeting with people, just getting to know people. If you've been to a rural area, if you're from a rural area, you can't just come in right blazing. You have to build those relationships and you have to start with just getting to know each other. All right, the second pillar that I want to talk about or approach is building trust. Especially when we're working with marginalized groups. Engaging in efforts focused on building trust and rapport is incredibly important. Sometimes that takes time and effort that we often don't think about sort of factoring into our research projects, but they're very, very important endeavors. That relationship building is key to make sure that that research can happen. There's also an important distinction about the difference between the trust of the researcher and the trust of the research institution. So if you are a researcher from IU School of Liberal Arts, from IU School of Medicine, and you are going into a rural area in Indiana to do work, you have to think about, what does that say? How do people perceive IU? How are people perceiving me? Are they mixing up the two? University of Kentucky, which is where we were all based, has a pretty positive relationship in the state of Indiana with different communities. It is the state school, but there had been a little bit of a history of researchers from UK going out to Appalachia and doing research and then going back to their ivory tower. So having that perception of, oh, there's a bunch of more UK people coming out to study us, right, was something that we encountered. And it was something that we had to work to build that relationship and build that trust and say, yeah, I am from UK, but I'm Katie and I'm here and we're working together and I'm really interested in your perspective and, tell me about your life and those sorts of things. So you have to consider who you are and who your institution is and how that might be perceived, particularly maybe how your previous colleagues have set a reputation, positive or negative. There's also throwing back to sort of the Aristotelian view of phronesis, where we have to think about this idea that through experience, through good mentors, through training, we can develop this sort of practical value-informed wisdom that as we are navigating these rural communities and these rural networks of people and these research studies that we want to do, we have to make sure that we have on that sort of value-informed hat as well. And that if we don't have the trust and the buy-in from our participants, not only is that not good for our research study, that's not good for anybody. That's not something we should be doing. So how can we get started with building trust? Well, I think the first place is to start with acknowledging your own positionality in your research and your own motives. And that's something that we should all be doing in our research on an everyday basis, but I think it's something that's particularly important to do if you are going into a community that you're not a member of and you're trying to develop those relationships and that trust. All right, the third, and then we've got one more, is relevance. One of the things that you'll find with a lot of communities, and particularly rural communities, is that feeling like the research topic and the research approach is relevant and has a direct benefit to them are important factors for whether these rural community members will even participate in your research. So if they don't find it relevant, if they don't think it's going to benefit them, they're not going to waste their time. And that's, logical. And so I would contend that we have to make sure that both our research questions and our outcomes have to be co-produced with our community members. I'm not saying everybody needs to take on a full-blown CVPR approach to every project that they do, but I do think that there are a lot of principles within the CVPR approach that helps us understand that any focus has to begin with a research topic that has importance to the community. So if we go back to the example of the Rural Cancer Prevention Center, we identified that cancer was a problem. It was a big problem. People were dying, people were getting sick. It was causing all sorts of other ripple effects. That was the health issue we wanted to address. But we spent months, years, getting to know the community, getting to know our stakeholders, doing formative research and focus groups and interviews and community events, learning what the community thought were the solutions and how they wanted to approach solving this health disparity. So while we may have come in both identifying what the health issue is that we know we need to address, everything else was co-produced with the community to try to solve that problem. So I think one place to start with this is, again, it goes back to you. It's doing that perspective taking and doing that reflective listening on what the community even thinks the problem is in the first place. So understanding why they think cancer might be an issue or why they think women don't come in and get Pap tests regularly. One of the things we found out is that in one of the, first of all, there's not a lot of clinics in the CRAD, the 8-county area. But one of the things we found was that there was one county where there was like a women's health clinic that everybody knew was where you went to get birth control. And so it had a separate entrance from the other part of the clinic. And women told us, well, if somebody sees your car parked out there, they know why you're in there, right? They know why you're doing something bad. You need to get birth control or you've got an STI or something like that. So it wasn't that they didn't think cancer was important or they didn't think these screenings were important. It was sort of the privacy and everybody knows everybody, everybody's in everybody's business. So just suggesting that we have a common entrance to the clinic was something that our community members suggested. We went to the clinic and worked with them and were able to solve that problem. Did that solve every problem? No, but it's an example of listening to your community members to identify, well, what is the solution here? How do we need to approach this? All right, the last is communication. And what do I mean when I say communication in research? I know the IRB tells us we have to have in our informed consent in our study information sheet. And I know Peter has some experience in working in that area with consent forms. But what I mean is separate from that. I mean a clear conversation about what the study purpose is. As researchers, sometimes we develop our elevator talk where we're like, here's the 30-second breakdown of what I do and what I'm trying to accomplish. What's the elevator talk for your research study that you can meet with participants and tell them what you're trying to do? How can you explain in layman terms the methods that will be used and why? Why am I using focus groups? What does that mean? Why did I make that choice? Why am I asking you to come and be a part of this focus group? And the outcomes and the findings are incredibly important to communicate back to the community. This communication has a couple of attributes that need to be checked off. It needs to be clear. It needs to be regular. It can't just be we come in, we tell you everything about the project, we do the project and we leave. And it also needs to be accessible. It can't be hidden in a journal article on some journal website. It can't be hidden on some sub web page of the CDC that nobody's going to ever go look at. Of all of these things, though, I think one of the things that we as researchers, we do a pretty good job of being, communicative with our participants throughout the study, but communicating research results and what we do with those outcomes and findings is often missing from that story. And so I'm going to put kind of a big quote up here on the board, but I really like it. And it notes that participants have a right to know the outcome of the research. This is especially important for participants with a direct interest in the findings, for whom knowledge can be power. Reporting back to participants is part of the discipline of transparency that keeps researchers honest and accountable. It fits within that responsibility that we have to foster public understanding and make patient and public involvement a core part of our health research. I just really like that quote because I think it leaves us all with some important reminders about what we need to do. So where can we start? Well, one of the things we can start with is a lay summary or an abstract. And increasingly, grant funding agencies are asking for this because they know it's incredibly important. And there are lots of great resources out there. My dear colleague, Krista Hoffman-Longton, whose office is right behind this wall, does a lot with this with the Alan Alda Center and communicating science. But figuring out a way to take a brief summary of your abstract and turn it into something that lay people can understand is a really good place to start because it gives you a framework for thinking about how to talk about this in ways that's not research centric, right? All right, so in closing, I think when we think about research with and in rural communities, I would argue and I would support the idea that these 4 pillars are what we need to be thinking about as we approach that research. We need to go in with topics that have relevance to the community through these respected gatekeepers who help us ethically go through those gates to access our populations and work with our populations. We need to focus on relationship building that centers trust and respect. We need to communicate the process and the findings along the way. I think it needs to be considered that we need to take the viewpoint that we're making an investment in these communities. We do more harm if we just go in and do a one-off study and we come back to our ivory tower and we publish it. Who is that helping except that single researcher who gets a publication? And I mean that. And I think we all need to examine ourselves if we think that we're going to be doing that ourselves. Instead, let's think about the investment in these communities that we can make. I want to end with a quote from one of my mentors from Kentucky, who now works at NCI, and she's just one of my heroes when it comes to cancer and rural health. She said, we can learn a lot about rural areas, and there are a lot of commonalities, but just like any research community that we work with, if you've visited one rural place, you've visited one rural place. So we can't just read about rural areas and go in and start swinging. We have to get to know each individual community. Thank you so much.
Oh my gosh. Okay, Dr. Head, wonderful. I'm gonna let you field your own questions from the room, such as it is, the virtual room. And I've got my own, but I'm gonna wait because I can ask them later if everybody else wants to have questions. How wonderful. Thank you.
Don't be shy.
Hi, Dr. Head. I just wanted to say thank you, and I actually just moved back to Indianapolis from Kentucky, and I worked with the Center on Drug and Alcohol Research at UK. So I did some research in Lexington and surrounding area. So it was really cool to hear about that project in Kentucky.
Yeah, thanks, Heather.
Matt put up his virtual hand. So
Oh, yes. Matt. Oh, you're still muted.
Got my picture there, forgot to unmute. Hi, Dr. Head, thank you very much. I'm Matt Ratelli from Eli Lilly. And how do you handle it when you're trying to identify that gatekeeper, and maybe even in your example where there's maybe multiple gatekeepers that have very different interests. And so how do you make sure you're really getting at the right ones that represent that community?
I mean, I think it's trial and error, but I think one of the most important things is starting with that investment and getting to know the community. You don't want to align yourself from day one with an organization that 4 weeks into the project, you realize nobody in the community trusts and they have a bad reputation, right? And that could have been avoided with just meeting with multiple stakeholders and meeting with multiple groups and trusted leaders in the community. You know, Indiana is a very rural state. I'm not from here, but when people ask what the state's like, I'm kind of like, well, there's Indianapolis and then kind of everywhere else. But there are a lot of great statewide organizations that have really good reach and have really good investment in both urban and rural communities. And sometimes those organizations are a good place to start, because if they are truly a community-based organization, they're going to be able to suggest people in those communities. So, for example, I work really closely with the Indiana Immunization Coalition, because I do a lot of vaccination research, and their reach is across the whole state. So I know if I want to go into a county, I start with them. Who should I reach out to? Who should I talk to? Sometimes those organizations can just provide those good people to talk to. So I don't know if that answers your question, but I think it would be just approach with you know, caution, and be you know, just like the first day of high school, you don't want to sit at the first table that has a seat. You want to get to know and kind of lay the lay of the land, so you know who you want to align yourself with.
Thank you.
Yeah.
I have a question for you, Dr. Head. So the question, it has to do with the return of results. And there's sort of, I want to draw a distinction between return of results. So there's one stage of that where, like, maybe a patient undergoes some kind of cancer screening or STI screening as part of their participation in research. And so what you return to them is their results. But the second stage of that would be what I think you're talking a little bit more about, which is a discussion with the community about what the research showed about the community, which is a different thing. And is something I don't think a lot of researchers do. And so my question about that is to sort of probe the controversy of that a little bit. What do you do when what your research shows about a community is likely to break the trust that the community has with you, like e.g., IV drug use induced HIV is a problem in your community, or something like that, where the community might respond and say, no, it's not. No, it's not. We don't want to hear that.
Well, I think I'd counter that and say, your community knows what their problems are, whether they want to admit it or not, and building that trust and working with them to identify what the research topic is from the start is going to help you, is going to help you do that. I mean, like I said, on the Rural Cancer Prevention Center, one of the biggest areas I worked on was the cervical cancer stuff. And it was one of the first times that I realized how important health literacy was. It wasn't just that people had maybe a little misunderstanding about how something worked. This was women who did not understand their own reproductive health, right? There were multiple focus groups where we had to stop the focus group just to offer a basic anatomy lesson so that we could understand, I don't just mean where the cervix is, but how many. I remember a woman was talking and she was like, wait, how many holes do we have down there? Right. And I just remember leading that focus group. I was with my faculty mentor at this time and realizing, wow, right. We have to reframe how we're thinking about this and address things that might seem silly to us. I'm getting a little bit off track, but I think part of the idea where I say we have to build trust and build relationships and have relevant topics and make an investment in the community is that even though we're pulling back the curtain on these problems, we're invested in helping those communities try to solve those problems. So are women dying from cervical cancer and colorectal cancer and breast cancer and lung cancer, even though these are preventable things? Yes, but oh gosh, here are some ways we can do it. And can we help you? And what people should we be talking to and those sorts of things. So it's a give and take, but I think it's that investment in the community where people are like, okay, we're ready to work with you to try to solve this problem.
Thank you. That's a really helpful answer in terms of, I think, reframing the research as the first step in providing.
Oh, I think you muted, but okay,
Sorry,
yeah.
in terms
Yeah.
of providing help to the community. Yes.
Yeah.
On the other hand, so I was calling myself. Again, Dr. Head, this is a great talk. And two things, I want to say something in the last question. So first thing is, this is a cresting wave, thank gosh. I mean, I think that I'm asking, you can have very interesting response to that, that CBPR was sort of a corner of research. And I would call the idea of working collaboratively with any community is becoming more and more central. It's an NIH topic, it's PCORI, one of my funders. And as a researcher who was sort of dragged kicking and screaming to do it, I'm a convert. I've drunk the Kool-Aid because I guess what I'd say is I like Jane's example because that's the fear. I would say that was my fear. I'll lose control and I'll be pissing people off by what I'm finding. And then my experience was the opposite. It was that if you had a relationship, no truth was a problem. It was always received, at least my experience, very positively. And Jane's example is wonderful because it reminded me like, oh, wow, that's right. That was a danger. That was what I was afraid of at the beginning. So I'd say this, if this is the future, I think it is now the present of research to do CVPR, deep collaboration with your communities throughout research, including rural. Two questions. One is, what is the number one barrier? Like, what is holding this up still? Number one, number two, if you want to say. I guess I'd say also, like, are there hopes for getting over those barriers? And last one is this especially hard in rural? Like, is this something you're seeing, like, we can do it in our urban communities, which again are about as far from the ivory tower as some rural communities, or is it just what is it different? Is it just a different, like you said, every community is different, so you have to do it differently everywhere. But I guess I would say, what is the barrier here? Because I feel like we're still struggling to make it happen.
Yeah, I think there's two barriers. I was thinking about your question as you were asking it. I think one is researcher ego, right? I think we do want to have control and we want to pose our clean hypotheses and do our study and have our journal that we're going to publish and those sorts of things. And CBPR approaches, community-based participatory approaches, that's what CBPR stands for. And you have to say it 5 times fast before they let you practice it. It's a little bit of an interesting term because people throw it around, but they're not always really doing it. And Peter kind of alluded to that. People throw it in their grants and then the grant reviewers are like, you're not really doing this. But I think CBPR approaches, which just centers that co-production of research, the collaboration with your participants. Researcher ego can be one of the most important barriers, right? Because we as researchers are really not trained to do that. I mean, we're only a few decades away from calling our research participants subjects, right? I mean, so we have to reframe how we think about the research process, and we have to teach it different. We have to mentor it different. I think the second major barrier, and this is probably not a surprise to anybody, is just the way we reward research in academia, right? And so I did not really fully realize how lucky I was to be at a place like IUPUI until I went up for tenure, and that I could have my community-based partners write letters of support, and I could take some of my public scholarship, which I didn't publish a journal article on, right? But I helped design and, implement theory-based, messaging in clinics and, offer expertise here and there. And so our university systems and our reward and promotion systems have to privilege that sort of, and there's different terms, public scholarship, translational research. I mean, just throw them all in a hat and pick one out. But if you're doing that kind of work, you have to work within a system that rewards that and allows for that. And we are incredibly lucky to be at a place that does that, because not every place is going to do that. Are rural areas particularly hard places to do CVPR? I would say it's one of the easiest places to do CVPR, especially if you go in with, that take your ego out of it and you're going in with pure motives and building partnerships. One of the defining features of most rural areas is community, right? And working together and tackling problems together. These people have often lived for generations in this area. They know each other, they know their neighbors. They're in everybody's business, right? So I would argue it doesn't come without its challenges, Peter, but I think rural areas are particularly primed to be not only open to, but you almost necessarily have to take a CBPR approach to do good research with those communities. Other questions? Is anybody working on rural research that you want to talk to us about, or we could problem solve if you're having an issue right now? You know, sometimes doing rural research doesn't necessarily mean you're in that rural community every day. I work really closely with my colleague Greg Zimmett on identifying urban-rural differences in vaccination and different vaccination attitudes and behaviors and beliefs. And we spend a lot of time surveying and interviewing parents, surveying and interviewing providers across the state, working with state agencies. And so sometimes that research does happen at a little bit of a higher level, but it's always about how do we get to that dissemination and implementation eventually. And we do that through our community partners that we work with.
I'm going to make people talk by threatening them with having to listen to me talk. Oh, there you go. It worked.
There you
Karen,
go, Karen.
I know it. So, oh, and Matt's back in. Okay, I'll be quiet now. Karen, how about Matt?
Oh.
Dr. Head, you may have addressed this in the very beginning. I was called out to chat with my IT person at the beginning of your talk. But I did want to ask you, you know, how are you defining rural versus urban, such as in the study that you just described?
Yeah, Karen, that's a really good question. I don't have a clear answer for you.
Oh.
In our survey research, we ask participants, you know, how they would classify the area that they live in, urban, rural, suburban. We can use zip codes to do, NIH has it's like a 10 category continuum from, you know, sort of how small the metro area is to, you know, to how, you know, how dense the population is. So you can do it on that kind of continuum. I don't really have an answer for you. I think sometimes I think how people identify their community is incredibly important in thinking about how rural it is. But there is no, you know, there are so many definitions of how we define rural that I don't really think there is a clear answer I can provide. Do you have a perspective?
No, I just was curious because I know that's such a difficult, you know, in our past experience, again, with I'm a project coordinator working with Peter. And I know in past projects, we were trying to define that. And I know Purdue, through I guess the Extension Service, has fairly in-depth, I guess, metrics, although clearly they have disclaimers that it's just their position, I guess, whether you look at population, whether you look at population density, or whether you look at services. But yet, you know, I live in what I would consider now a rural area, but my internet is pretty good. And after our ops meeting, when was that Wednesday, where Peter and Heather, who I would consider live in a very urban area, had horrible internet service. And back to, you know, healthcare. Folks in, you know, Greenwood and some of the southern Indianapolis areas really don't have access to hospital care, which is, you know, amazing. And they are very much in an urban area. So anyway, it's just incredibly muddy, and to try to categorize someone as urban versus rural is just so difficult. So difficult. So
it really is. Where I grew up in Texas, you were rural if you didn't have a Walmart. That was how we kind of categorized it. So if you didn't have a Walmart, you were really in the sticks.
But you can go to some very affluent areas in this country that do not have Walmarts or any box stores that are, you know, have every service imaginable at their fingertips. So they would absolutely blow that definition. Yeah, so thanks.
Yeah. Matt?
Yeah, are there any special considerations around either, sharing the data with others or secondary research when it comes to these communities? Because especially if the community itself is defined, like, you get all this trust through your research, and then someone can come along and even if it's de-identified or whatever, do something that maybe could just blow that apart.
Yeah, well, I mean, there are a lot of sort of de-identified data sets, right, where we're able to sort of draw some of these conclusions that we have about these higher level health disparities and things like that. But yeah, I think, I think to your point, I think if we're going to build trust with these communities and that they trust their data with us, we need to explain how that data is really going to be used. And if something changes, we need to, alert the community. So I think that just goes back to that, Aristotle's phronesis. We have to, as we're navigating these different situations, we have to sort of inject some values in our decisions and how we approach things and make decisions about things. And we should, right? We shouldn't leave all of the sort of ethical considerations of our research to that IRB approved it. So we're good to go, and let's just do whatever we want from here. Not that any of us would do that, but I think that's sort of the, all right, we've protected our human subjects. Let's do our project now.
Thanks.
There was something in the chat. Russ, it was McDonald's. Yes, Emily, we didn't have a McDonald's or a Walmart. We did have a Sonic, because every Texas town has a Sonic, which is one of the saddest things about Indy, is that I think there's a Sonic and it's way on the, oh, Emily, you know where it is. You'll have to take me there someday.
I'll be respectful of time for you, Dr. Head, and also the rest of our participants. I will say one thing about the co-production aspect of what you were describing. I would say that in my experience, that was as with a researcher's ego. Just, that's the fear, like, oh my God, I can't do the research I want to do. And then from my experience, it was, again, an urban environment here. It was actually, in some ways, being surprised again how natural it was. Maybe your cancer case showed as well. It's like, boy, are we on the same page. Like, if you're doing the right kind of research, you won't find it hard to find co-production, because you're not asking them to be scientists, but you're also asking them to give you insight on their experience. And it really can work. As with all relationships, it's work and it takes time, and there are frustrations and annoyances. But it's also the greatest payoffs possible. There was a time when my early research project, I walked into the community group saying, I'm giving up on this. I don't think it's important anymore. And they said, no, it is important. This is my experience. This is how it's important. So this is my experience. How it's important. So, okay, we should go forward with it. And we got the grant, we did the project. But I really look back at that as a case where I was fearful, as you said, number one barrier, fearful of sharing the planning and the direction. And then I learned that it was safe and it was actually a good experience. So
yeah,
I like
and to build on that co-production idea, I am talking about, kind of checking your ego at the door and approaching it as a partnership. I always let my participants know, like, here's the expertise I bring to the table. I'm a communication professor. I do this kind of research. Here's some of the stuff I've done in the past. You are the experts on this. Is that right? What other expertise do you bring to the table? So we have a little bit of a moment of, we're going to level the field here before we start this interview or this focus group or this stakeholder meeting, because I am not the end all be all, right? I don't know everything that's going on. That's why I'm here. And you bring really valuable expertise. That's a really important strategy that I was taught as a grad student, like, if you're conducting focus groups or interviews, to really get your participants to open up. And then I realized, wait, that's actually true, right? It's actually true. That shouldn't just be a strategy, that is incredibly true. And so I always try to approach it that way.
That's a lovely note to end on. Unless you have any last comments, thanks again, Dr. Head, and everybody for being here. Nice, I really enjoyed the conversation too. So this all gets posted on the Treats website. I'll send links. We can send links to everybody at this meeting. There also, Dr. Head mentioned, there are some resources she may be able to share. There may be able to guidance if you're taken by this topic and you want to do more or learn more. We can provide those resources. Also, you can always get a consultation from the Bioethics group, our group from CTSI, or I'm guessing that Dr. Head accepts emails as well and is happy to help people with questions. So Thanks all, and thanks again, Dr. Head.
Thank you.